Good afternoon and happy Monday, everyone. Hope you guys are doing well. If you can drop in the chat where you are joining from, that would be awesome. Welcome, Floridian, fellow Floridian. Awesome. Hey, Puerto Rico. Awesome. Welcome, welcome. A lot of states up north. I'm sure it's quite chilly where you all are. We're gonna wait a couple more beats. I still see some attendees rolling in. Just give it a few more seconds and then we'll get started. All right, welcome everyone. My name is Christy Navarro and I'm going to be the moderator for this particular panel. So we are a project at the Nova Southeastern University university, and we're all part of the Dr. Karen C. Patel College of Osteopathic Medicine. Our project is called the Mental Health Literacy Project, and it's funded through a quality of life project that's funded by Nova Southeastern University. So just a little bit about us. Again, my name is Christina Navarro. This is my amazing team. We have a few folks missing, but I'm an assistant professor of public health in the College of Osteopathic Medicine, and I'm also the principal investigator and project director for this particular project. Today, I'm joined by three of my research assistants, Shannon Parma, Zara Aziz, and Sami Doranala, and they're all going to be presenting on our panel today. And although they're not here, I want to make sure that I give a shout out to our community partner, which is the United Way of Broward, through which our project wouldn't be what it is today without them. So wanted to mention them and thank them for that. So just a little bit of housekeeping. We are going to be, I will be going through a background of our project and a little bit about our current study, which is a smaller part of our bigger project. Then each of us will be presenting on our different factors with the socio-ecological model, which I'll talk about in a bit. We'll have some time for moderated discussion and synthesis of what we found, and we'll have some time for Q&A. So as you have questions, you are welcome to drop them in the Q&A box that's should be at the bottom of your screen. And we'll get ready to go from there. So just a little bit of background on our topic. So as we all probably know, this is probably not at all a new thing for any of us, but mental illness is not just a nationwide issue, it's also a global issue. And since the pandemic, which unbelievably was started 3 years ago, we've seen an increase in mental health issues and factors that affect mental health issues during this time. Especially affected during this period of time were young adults, and we saw a significant and disproportionate rise in anxiety and depressive disorders with young adults reporting just about 50% that were with these particular diagnoses during this time. A recent study came out from the CDC showing that post-pandemic health professionals as well, doctors and folks who work in hospitals also are reporting high rates of burnout, and which can lead to mental health challenges as well. And this has been higher since the pandemic. So back to our young adults. So where do we find lots of young adults? We find them in colleges and universities. So these particular populations experience a high prevalence and burden of mental illness. One of the reasons is because young adulthood is a frequent time of onset for mental illness. It's also a frequent time that individuals may get their first diagnoses, have their first episode, as well as the demanding and academic stressors and challenges that might be going on, which may exacerbate that as well. So as we know, mental health challenges, especially severe ones, can affect academic success. It can affect dropout rates, and all of these combined can affect future outcomes. So it's really important that we focus on this particular population, not only for their own mental health and for their future, but also for the individuals that they're going to be serving in the future. So one of the ways of doing that is improving their mental health literacy and helping individuals in universities and college environments as well, helping them while they are going through lots of struggles is a great idea in order to approach improving their mental health by improving their mental health literacy. So I may be speaking to the choir at a mental health health literacy conference, but what is mental health literacy? So it is derived from this field of health literacy, and it refers to mental health knowledge and attitudes and beliefs that are linked to actions in recognizing, managing, and preventing mental health disorders. So as you can see from the definition, it's very similar to other areas of health literacy for other chronic diseases and things like that, except this is specifically relating to mental health. There are 7 mental health literacy attributes, and these were coined by Jorm way far away in Australia. And these 7 attributes are what are said to contribute to mental health literacy. So an individual who has able to recognize specific disorders, knows how to seek mental health information on their own, knowing what risk factors and causes of disorders are, knowing how self-treatments and how to help oneself, as well as how to look for professional help available and knowledge of what professional help is available. And then also attitudes that promote recognition of disorders, as well as appropriate help-seeking behavior. 6 and 7 are often intertwined with mental health stigma issues as well. And so these are the 7 attributes for mental health literacy. So our project strategy, I'm going to give you the overall project strategy and just let you know which one we're focusing on today. So our project strategy was to improve mental health of our university population by increasing levels of mental health literacy. So this is a year-long grant program that we have. We've been extended for another few months to kind of finish out with our programming. But it started off with a baseline survey of mental health literacy. And we captured information, of course, demographics, but also information about mental health experiences, mental health education, as well as our mental health literacy scale score and levels. And we'll talk a little bit about that. The next part, phase 2, was our training intervention, which was mental health first aid. So for those of you who are not familiar with mental health first aid, it's an 8-hour training that's administered by a certified instructor. And this is through the National Council for Mental Wellbeing. So we had these training interventions on campus. And then once these individuals were trained, we went back and looked at whether this 8-hour training was able to increase their mental health literacy, as well as their confidence in applying mental health first aid skills, and satisfaction with the mental health first aid training. And one of the main things that we're looking at is whether this is a viable training for our university community. So today we are focusing on the first part, which is just our baseline information and really looking at that first mental health literacy score. And I'll talk a little bit more about that in the next upcoming slides. So this particular part of our study is a cross-sectional design used to investigate the relationship between mental health literacy and some socio-demographic factors in our university community. And we'll talk about our sample in a bit. We collected data via an online survey. All information was captured through REDCap. Folks were selected if they wanted to participate. So we had a volunteer response sample, and we collected this baseline data between December of last year and August of this year. Our inclusion criteria were individuals who were 18 years or older, adults. They had to, of course, be willing to participate and were student, faculty, or staff members at the university. So really anybody who was part of our community, university community, were welcome to participate. Our overall measures, I mentioned them before, but we looked at various socio-demographic characteristics, but we also asked specific questions about mental health experiences, mental health education, and then we looked at the 35-item mental health literacy scale, which has really great validation. So that's our overall study and kind of what we're focusing on today. So I'm going to get into kick off our different sections. I'm going to talk about first our socio-ecological model of mental health. So socio-ecological model is one of the public health frameworks, and basically what that looks at is there's multiple influences on health, and we have socio-ecological models for every type of public health issue that's out there, including mental health. Meaning that the health of an individual isn't just due to their attitudes, behaviors, and their skill set, but it also has to do with all other areas. So whether it's family, friends influencing their decisions or attitudes, or maybe institutions of work or education, or even their communities or policies, or even in the environment can influence health. So we are working off of this framework, and each of us will be looking at variables that are part of these different levels of the socio-ecological model. So I'm starting off with the individual level, and specifically what I looked at was this concept of individuals with a mental health experience. So I'll talk a little bit about that going forward. So there are many factors that can affect mental health literacy. Just really looking at that rainbow of the ecological model, there's lots of different things that can affect mental health, and we've seen this in multiple studies in various ways, of all different ways that mental health can be influenced. But the same for mental health literacy as well. So some things such as age, gender, education, and culture, which two of my research assistants will be talking about today. And history of mental illness is also something that can increase or possibly influence mental health literacy. Previous research has found that there's higher mental health literacy among individuals who have a lived experience with depression or anxiety. And there's also research that indicates that even indirectly, so being around a family friend or a family member or a close personal friend that has lived experience, you're seeing them struggle, you're seeing them going to their appointments, you're maybe helping them with with their recovery. Those individuals often have a higher mental health literacy as well. So why is this important to study? Why is it important to study in our particular environment? So, mental health literacy, just like overall health literacy affects an individual's ability to make good decisions about their health. And when we think about it, it also has to do with them making good decisions about other people's health. For our community, we have a very strong health professional schooling programs here at our particular university. So we have a lot of individuals who are going to be going into these health professions and helping professions. So the better that they're able to not only make good decisions about their mental health, might be better ways for them to help individuals that they serve, like their patients and things like that. So understanding factors that are associated with mental health literacy, meaning things that could possibly influence it in a good way or in a bad way, can possibly inform interventions in order to improve literacy and to promote overall well-being. So I want to talk a little bit about the mental health literacy scale. So I'm going to be covering this in my presentation, so my research assistants won't be repeating this over and over. So the mental health literacy scale is back from, I think, 2015. It's a 35-item survey that measures literacy and mental health knowledge and attitudes. It looks at 6 of the 7 attributes by Joram. The score ranges from 35 to 160. For the most part, they are Likert scored questions with the different attributes. And in this case, higher scores indicate a greater mental health literacy, and it has a really good internal consistency with a Cronbach's alpha of 0.88. The other construct that I'm looking at was mental health experience, so at the individual level. So we asked 3 questions about mental health experience, whether an individual had either experienced either currently or sometime in the past their own personal struggle with mental illness or mental health challenge, whether there was a family member or a close personal friend or peer that they were, that they knew that were experiencing an illness, and whether they are currently seeking or have sought professional help in the past. We looked at each of these variables or each of these questions individually, but then we also summed them as well. So maybe not looking at them separately, but just how many do you have? So we had either 0, meaning you had no mental health experience at all. So 0 to 3. So you either had 0, 1, 2, or 3. Our analytic plan, we reported out frequencies, means for our mental health literacy score, and standard deviations. We did correlation tests to investigate the relationship between our mental health literacy score as well as the individual attributes. So most studies that we've looked at in the past, they just look over the overall mental health literacy score, but we were very interested in looking at the specific attributes. So we pulled down those specifically. And then we looked at, of course, mental health experience and sociodemographics as well. Independent t-tests and one-way ANOVA tests used as appropriately were employed to compare mean MHL score differences in our groups, and I'll be showing that to you going forward. So some overall results, we had 288 valid questionnaires after removing incomplete. So we only looked at complete sets. Our average age was 27 years. So that's, as you can see, that's a little bit older than an undergraduate student. So we had grad students, undergrads, everything. And our age ranged from 18 to 62 years old. Our sample was mostly female, mostly heterosexual, mostly students, but when we drilled down, we're mostly graduate or professional students, such as medical students. We'd say about 40% of them were unemployed, which makes sense because they're students, and 27.8 of our individuals or samples worked full-time. So what did we find? So when we looked specifically at mental health experience, most participants, 88% of them, reported at least one mental health experience. So not looking at which one it was, but we just looked at that number and we saw that 88% of them had at least one of them indicated on there. And more than 1/3 had experienced all three, meaning that they had a personal struggle in some way, they had sought help, professional help, and they had a family member or a friend that had an illness as well. When we looked individually at each of the mental health experience types, most had exposure to a friend or family member with a mental illness, and about half, a little bit more than half, had a personal experience with a mental illness and sought help from a professional, respectively. When we looked at the mental health literacy scores, our mean mental health literacy score, MHLS, was 134.3, and this is out of 160. So if we did the math, we did the percentage, they scored about 83.9%. So not 100%, but they did pretty good. And then we drill down and look specifically at each of the attributes, which you see below. So this table shows the minimums and the maximums, as well as the mean scores and standard deviations. And then we did that percentage, right, of you know, kind of how close they got to the maximum score. So we were able to look there and we saw, for instance, knowledge of risk factors scored at 66.5, and knowledge of self-treatments, we had a 79.1. So we had, you know, a range in scores for there, but for the most part, they did pretty good when we looked at the overall mental health literacy score. So we looked at correlations between our mental health experience variables and each of these particular mental health literacy attributes. And mostly what we found for the individual mental health experiences, we found weak significant correlations, but they were positive. And when we looked at the total mental health experiences, so just looking at the number, we found some strong and some moderate positive correlations here. So our strongest correlation, you know, was between total mental health experience and attitudes that promote recognition and help seeking. And usually we use that variable for looking at like stigma and anti-stigma types of attitudes around mental health. So really looking at that association between mental health experience and stigma, attitudes and stigma. So we also found, moderate correlations for ability to recognize specific disorders, knowledge of how to seek mental health information, as well as knowledge of professional help available. So then we did some t-tests and ANOVA to look at the mean mental health literacy score. Now, we didn't do this for all attributes because we would have been here all day, but we just looked at the overall mental health literacy score. And what we found were significant differences across the board between all mental health experience types, as well as overall number. So for the t-test, which looked at the individual mental health experiences, we found significant differences between those who had the experience and those who did not have the experience. And what we found was those that had the experience had a higher mental health literacy score. For the total mental health experience, adding them up, we found significant differences with the number of mental health experiences, and the higher the number of mental health experiences, the higher the mental health literacy. So we were able to see that linear progression there. So overall, we found that mental health literacy was adequate with this community. And for our correlates, we found that there were moderate associations for disorder recognition, how to seek information, as well as professional help available. And for our means, we found that there was a strong association between attitudes for recognition and appropriate help seeking, as well as some other findings as well. So what does this all mean and why is this important? So we found mental health literacy score were pretty adequate in this particular community. In the original study, in our study, the mean was 134. In the original study, when they looked at the community sample, which were undergraduate students in a psychology class, which is normal, their average score was 127. Their mean score was 127. So our group was higher than that. And when they looked at mental health professionals, the mental health professional score was 150 in the 150s. So we were kind of right in between, not the undergraduate level, but also not the mental health professional level either. So while we're not, all the way at the top, that tells us that we still have some work to do. And when looking at those specific attributes, it gives us an idea of how that can inform future programming. So if we were to do a targeted program, we can focus on those particular attributes like self-treatment, as well as knowledge of risk factors and causes and things like that. So with regards to our mental health experiences, we saw that direct and indirect exposure to mental illness is associated with increased mental health literacy. So while we don't want to increase mental health literacy by giving people mental health challenges, but one of the things that we might be able to do is, especially around decreasing stigma, is allowing people with lived experiences to share their stories, and giving folks who may not have experiences some insight, right? Because they have a specific insight into the mental health or the mental illness treatment world, and that's something that they might be able to share with individuals that don't have that experience. Finally, more exposure to different types of mental health experiences, the greater the mental health literacy, which is interesting that it wasn't necessarily a specific type, but really kind of the more well-rounded your experiences were, the better or the higher, I should say, your mental health literacy as well. So again, it might be helpful to really, as we look at possible programming for the future, to make sure that we involved individuals with lived experiences, or who are caregivers or family members, who again can share insights into what works best with this type of programming. So in conclusion, for my part, so this research has the potential to identify specific groups that might need some additional support, and in specific areas as well when we look at those individual attributes. And public health promotion efforts and mental public health promotion efforts around increasing mental health literacy, and of course decreasing stigma around mental health, should consider incorporating these insights of individuals with lived experiences. So that is all for my portion of it. So thank you very much. Next, we're going to have one of my research assistants, and she is going to focus on the interpersonal level. So I'm going to be moderating and doing the slide advancing. So I hope I'm going to be doing that all right. So next up we have Zara Aziz, and I'll let you get started, Zara.
Great, thank you. So hello, today I'll be discussing the perceived family openness to discussing mental health and its association to mental health literacy. A little bit about me. I'm a public health major and a junior at Nova Southeastern University under the Kiran Patel College of Osteopathic Medicine, and I am a research assistant for Dr. Navarro on the Mental Health Literacy Project. So a little bit about the background, the importance of family support. So as we all know, social support is a very important factor for mental health in general. Specifically, family support can influence positive attitudes about help seeking, and family plays a crucial role in an individual's mental well-being, as well as coping with mental health challenges. A supportive family environment contributes to increased mental health literacy and reduced stigma. And then as for the family communication and mental health, both are linked to improved mental health outcomes, and open family discussions about mental health can enhance individuals' comfort and helps in seeking help. So we did identify existing research gaps, which include the relationship between perceived family openness and an individual's mental health literacy, as well as how cultural and demographic factors influence this relationship. Due to these existing research gaps, our rationale for our study was to investigate the link between perceived family openness and mental health literacy, which can help inform mental health promotion efforts. It can also help us understand the role of family dynamics in mental health literacy that can lead to more effective interventions. So we defined perceived family openness as a comfort in speaking with family members about mental health topics. So a few examples of this could be stress and stress management. So we did ask 2 questions to participants, one of which was, growing up, were your family members open to talking about mental health related issues with you? So for example, stress, emotional wellness, mental illness, suicide, etc. And the second one was, as an adult, do your family members currently discuss mental health related issues with you? We did also factor for socio-demographic characteristics, including age, sex, perceived economic stress in childhood, parents' highest education level, and relationship status. As for our analytic plan, we did include descriptive statistics, which were basically us reporting out on frequencies of demographic variables. So that would include the number and percentage of individuals who answered certain demographic questions that we had asked them. We also included the Spearman-Rose correlation test, which measured the correlation between mental health literacy and the family openness questions that I had just discussed. We also included independent t-tests employed to identify differences in mental health literacy based on family openness groups, and we did set the statistical significance at 0.05. So for our results, as for socio-demographic characteristics, most, so around 61.8% of participants perceived their family's financial situation was stressful while growing up, and greater than 75% of participants reported that their parents' highest level of education was a college degree. Next slide. As for perceived family openness, most participants, so around 69.1%, responded that they did not feel that their family encouraged discussions about mental health related issues while growing up. But conversely, 58.7% said that their family currently discusses mental health related issues with them. Our results, as for the correlations, we did notice that there was a weak positive correlation between family openness in adulthood and mental health literacy. And for mental health literacy attributes, weak positive correlations were found between family openness in childhood and knowledge of how to seek information. Family openness in adulthood showed weak positive and significant correlations with all mental health literacy attributes except knowledge of risk factors and causes. So I'd like to highlight here that these were all weak positive correlations, and we would like to investigate further since we did not look at specific groups. And that could mean looking at people under the age of 25, for example, dividing up the data by sex, or even including different subgroups such as medical students. So while we were looking at the entire sample, it would benefit us to look at specific groups in the future. So for our results for the independent t-test, for family openness in childhood, we found no significant differences found for mental health literacy and most mental health literacy attributes in relation to perceived family openness during childhood. Significant difference was observed in the attribute of knowledge available professional help, with higher scores in participants from open families. As for family openness in adulthood, we did find significant differences observed between participants currently discussing mental health topics with their family and those who do not. We did find significant differences between mental health literacy overall scores and 5 of the 6 mental health literacy attribute subscores. So overall, scores were higher in participants currently discussing mental health topics with their families. So just to summarize our findings, as for family openness, most participants did not perceive that their family was open to discussions on mental health related topics in childhood. As for childhood, participants who felt their parents were open to discussing mental health topics in childhood had a higher mental health literacy attribute score than those who did not perceive family openness. And finally, for adulthood, we noticed that mean mental health literacy scores were higher in participants who have current discussions with their family about mental health compared to those who do not. Just to further discuss, so for family openness to mental health, the background of parents having a college degree and financial stress suggests that socioeconomic status and education level may not necessarily correlate with open communication about mental health within families. So basically, the lack of perceived family openness to mental health discussions in childhood may indicate the presence of stigma or discomfort in addressing these topics. From the literature, other studies have shown that the absence of family discussions about mental health can contribute to the perpetuation of stigma and hinder help-seeking behaviors among children. As for correlations with mental health literacy attributes in childhood, the weak positive correlation between knowledge of how to seek information and family openness suggests that family discussions may enhance the ability to find information on mental health. This finding indicates that family support can be influential in equipping individuals with the skills to access resources for mental health with the focus on knowledge. Other studies have also supported the notion that family discussions positively impact mental health literacy and awareness, which is consistent with the observed correlation from our study. Finally, for correlations with mental health literacy attributes in adulthood, family openness in adulthood is associated with improved mental health literacy and awareness. This lack of correlation with knowledge of causes and risk factors may suggest that specific knowledge in this area might be more influenced by factors outside of the family. Other studies have supported the positive correlation between family discussions in adulthood and mental health literacy, indicating the importance of ongoing family support and communication in these aspects. So in conclusion, family support is an important factor for increased mental health literacy. From our study, we did find that in childhood, individuals have the perception that they are not able to talk to their parents. So interventions and programming in the future may include establishing better communication in families while these children are growing up, since we are noticing that this is not happening until adulthood, these important conversations needed for increased mental health literacy. Thank you.
Thank you so much, Zara. We are going to switch gears and we are going to be heading on up to the institutional level. Specifically, we're going to be looking at schools. So next we have Shannon Parma, who is going to talk to us about education.
Hello, everyone can hear me, right?
Yes, we can. Thank you.
Just making sure. All right. Hello, everyone. My topic is the influence of education environments on mental health literacy. My name is Shannon Parma. I'm a third-year PhD student in the couple and family therapy with Kiran Patel College of Osteopathic Medicine in Nova Southeastern University. I'm also a research assistant for the Mental Health Literacy Project. Because I'm a PhD student, education and teaching is very, I have a lot of passion for it, as well as the mental health, because going through the programs as a student can be very taxing. So this definitely was a great way for me to investigate some of those correlations. For a little background, I know that you've probably heard this ad nauseum, but mental health literacy relates to help-seeking behaviors The stigma associated with mental health can impact mental health literacy, and interactions with individuals with mental illnesses can also impact mental health literacy. So those are the three big factors influencing mental health literacy. But what about education? Studies have shown that education does have an influence on mental health literacy. More specifically, higher education is significantly and positively associated with mental health literacy. To dive in a little bit more specifically, we'll be looking at formal institutions and the impact of its impact on mental health literacy, and those being primary school, secondary school, the college and university level, and the informal education. I'll talk a little bit more about that. So primary schools and mental health literacy, there is little to no research on the relationship between mental health literacy and mental health education in primary schools. Primary schools could be the optimum setting for mental health education to enhance mental health literacy, but they're, again, still very limited on what we know about that. Secondary schools and mental health literacy, there have been interventions involved in secondary schools to show a relationship between mental health literacy and secondary schools. So schools that offered web-based mental health education programs improved their students' mental health literacy. Also, schools that integrated mental health discussion in their curriculum increased their students' mental health literacy. And also, students who did not receive exposure to mental health education in secondary schools have a lower mental health literacy than students that did. And that tends to be the more common finding, is that secondary schools are not consistent in providing mental health literacy education. At the university level, students with a university education had a higher mental health literacy than students who did not attend university. More specifically, students with at least a bachelor's degree had a greater mental health literacy than students without a degree. And students between about 18 to 24 years who attend university had an above average mental health literacy. So their score on the mental health literacy exam was higher than the average. Informal education is how students are absorbing information outside of the classroom. So those are things such as books, magazines, newspaper, television, radio, social media. And all of these have been shown to increase the mental health literacy in students because of that increased awareness. Also, voluntary participation in programs such as mental health first aid programs have increased mental health literacy. Unfortunately, there are some gaps within the educational level and mental health literacy. So how much mental health exposure do university students receive in their education? Is there a relationship between education level and mental health literacy attributes? And what are the factors within education that impact mental health literacy? So these three questions have not really been well investigated, and hopefully our research will shed some light on it. So to sum it up, our objectives are to determine the mental health literacy in a select population of university students, to evaluate any relationships between education level and mental health literacy, to analyze specific educational factors related to mental health literacy, and to offer recommendations based on these results. So in order to screen for the education factors, we asked a few different questions. For example, was mental health education taught in primary, secondary schools? Did you take a psychology or mental health related course in college? Did you participate in mental health related training or workshops? And have you conducted a self-directed search for information? I know that my colleagues have talked about their socio-demographic factors, but more specifically honing in onto education level, about 68% had a bachelor's degree or higher. 49.6%, so almost half of our participants were enrolled in a master's degree or higher, and 62% were part of osteopathic College of Medicine programs. So our statistical analysis where higher levels and scores were related to a higher level of mental health literacy. We used the Spearman's Row Correlation Test to investigate the relationship between mental health literacy and education factors and socio-demographic factors. We utilized an independent t-test to determine the differences in mental health literacy based on different mental health education variables. And we considered anything significant that was a p-value of less than or equal to 0.05. So the results of our correlation analysis were there were no significant correlations between mental and emotional health education in primary school and mental health literacy. There was a weak positive correlation in between psychology or mental health related courses in college and mental health literacy. And there was also a weak positive correlation between mental health related trainings or workshops that were taken by participants and mental health literacy. To go on a little bit further, there was a weak positive correlation with self-directed searches for information about mental health. And there was a weak positive correlation with the attitudes that promote recognition and help-seeking behavior and education level. So this chart really goes into more specific. As you can see, the gray with the asterisks next to it, those are what were considered significant. See, primary school, we did not yield any significant correlations. However, training and self-directed were with one or two components of the mental health literacy attributes. Overall, though, the college course had the most correlation with mental health literacy attributes out of all four that we studied. For the independent t-test, there was no significant difference for the mental health literacy score with primary schools and students that took training and workshops. So that's the overall mental health literacy score. There was a significant difference in the overall mental health literacy score with taking a psychology college course and a mental health related course in college. And there was also a significant difference between the mental health literacy overall and self-searching for mental health information. So what does this all mean? Okay, mental health literacy was adequate in this university community, with the average scores being lower in knowledge of risk factor causes and self-treatment. Now, recent studies have concluded how mental health literacy in university students varied by the students' socio-demographic factors. So because of the high education level or the more exposure to mental health discussions, that could be a factor into why our university population was adequate in their score. Also, university students such as medical students had a higher mental health literacy and help-seeking behaviors. So this is pretty consistent with the variance with the mental health literacy score, but some of the attributes not being significant. There was also no significant correlation between mental health literacy scores and having received mental health education from primary or secondary schools. Based on the research, this has shown that there's a lack of standardized curriculum that contributes to the lack of correlation with the mental health literacy scores. Also, secondary schools that implemented mental health interventions showed improvements in mental health literacy attributes, but again, this has not been consistent. This is not something across the board that all schools are incorporating. Taking a college course was significantly and positively correlated with how to seek information, knowledge of risk factors and self-treatment, and help-seeking behaviors. And this was consistent with the studies that were done. Undergraduate students who took an online mental health class improved their mental health literacy. Mental health courses offered at the university level improved students' mental health knowledge. And university students who took a psychology course or even majored in psychology had a higher mental health literacy score than university students of different majors. Trainings were significantly and positively associated with knowledge of how to seek information, and self-directed searches were associated with attitudes that promote recognition and help-seeking. So again, this was very similar to what's been out in the studies, that research on mental health first aid trainings on university students showed an improvement in mental health literacy and mental health literacy attributes. Also, a mental health awareness and advocacy curriculum improved mental health literacy in university students. So even though it didn't impact overall, it does impact, the certain attributes within the mental health literacy. And overall, education has shown to influence mental health literacy based on our study. Mental health related education programs or interventions can benefit the mental health literacy of students. Courses offered at the university level appear to benefit mental health literacy more. So mental health education should be targeted more at the university level. And that is all. Thank you.
Thank you so much, Shannon. We are going to shift gears and head on up our rainbow, and we're going to head to the community. So first, let me say so. Sammy's going to be talking about culture, and we define culture in different ways. She's going to talk more about that. So sometimes we put this aspect of culture with community, but it can also go to societal culture as well. For the purpose of this particular study, we're going to leave it at community, and Sammy's going to move forward and talk to you a little bit more about cultural factors.
Okay, hello everyone. My name is Samhita Doranala, and I will be discussing culture, religion, and country of origin on mental health literacy. So a little bit about me is I'm a public health major and a junior at Nova Southeastern in the Kiran Patel's College of Osteopathic Medicine, and I am a fellow researcher. So, mental health literacy can be affected by various external factors, and one being mental health stigma. And perceived cultural and religious attitudes and beliefs about mental health can both influence and perpetuate that stigma. And research suggests that an individual's country of origin, religion, and culture can be a significant influence for mental health related behavior due to the differences in perceptions and stigma surrounding mental health. So, for example, in Asian cultures, mental health illness is often disregarded as physical complaints or undermined as a basic emotion, maybe equating depression to sadness or associated with the work of spirits. So, this study aims to investigate the relationship between culture, religion, and country of origin and mental health literacy, including knowledge, attitudes, skills, and behaviors. So, in regards to perceived cultural openness to mental health, two questions were asked in relation to participants' perceptions, whether their cultural traditions encouraged discussions about mental health related issues, for example, stress, emotional wellness, mental illness, suicide. And one question asked about perceptions of cultural openness during childhood. And the second question asked about these perceptions as an adult. So before we continue, cultural traditions, we gave a broad definition, naming it cultural openness instead, because different individuals have different definitions in regards to culture. Some define culture as their country of origin or their parents' country of origin, maybe their ethnicity or their race, or their religion. So cultural openness is just a term that we're using for individuals to and participants to provide their own definition for. And then for the socio-demographic characteristics, we obtain data information on age, sex, race, ethnicity, years lived in the United States, country of origin, parent country of origin, religion, and religiosity. So for the statistical analysis, descriptive statistics were used to characterize the participants' mental health literacy and scores of each attribute. Higher levels in scores corresponded to higher levels of mental health literacy. And the Spearman's-Rose correlation test was used to investigate the relationship between mental health literacy, cultural openness, and socio-demographic characteristics, while an independent t-test was used to determine the differences in mental health literacy according to the cultural openness groups. And our p-value was set to less than or equal to 0.05 as statistically significant. So we found that the average age was 27.31 years from ages 18 to 62. And there were 240 female participants making up the majority, and 46 male participants making up the minority at 16%. And then for race and ethnicity, 45.1% of participants were white, 25.5 were Asian American or Asian, 19.1 were Hispanic or Latinx, and 15.3 were African American or Black. And then the participants' country of origin spanned 29 different countries, with most 83.3% being born in the United States. So this map is just to visualize that. And then 8.7% of participants lived in the United States for less than 10 years, and 8% lived in the country for 10 or more years. And then most of the participants, 66%, had at least one parent that was born outside of the United States. And then more than half of the participants, 55.2%, indicated that their religion or spirituality was important to them. And most, at 43.2%, reported Christian religion, 10.4% reported Hindu. And of the sample, 12.9 claimed to have no religious affiliation, and 8.2 identified as agnostic, and 2.9 identified as atheist. So, for perceived cultural openness, most participants responded that they did not feel that their cultural traditions encouraged discussions about mental health related issues in both childhood, which would be 78.8%, and adulthood, which was 64.3%. Now, to move on to our correlation analysis, it showed that there were weak negative correlations between Asian American and Asian race and perceived cultural openness in childhood and adulthood. There were also weak positive correlations between white race and perceived cultural openness in childhood and adulthood. And then we also found that next slide. We also found that there was no significant correlation between perceived cultural openness and religious affiliation, and there was a weak negative correlation between the length of time in the United States and perceived cultural openness in childhood. There were also weak negative associations between parent country of origin and perceived cultural openness in childhood and adulthood. And then for the mental health literacy attributes, there were no significant correlations found with the cultural openness variables and some attributes. However, there were weak positive correlations found between perceived cultural openness in childhood and knowledge of how to seek information and knowledge of risk factors and causes. And there were also weak positive correlations found between perceived cultural openness in adulthood and knowledge of how to seek information and knowledge of risk factors and causes. So moving on to the independent t-test, we found that there were no significant differences for the mental health literacy scores for the cultural openness in childhood and adult groups. And it also showed that there was a significant difference between the mean scores of participants who felt their cultural traditions growing up were open to discussions on mental health related topics, and those who did not perceive cultural openness on the mental health literacy attributes, knowledge of how to seek information, and knowledge of causes and risk factors. And the same was found for cultural openness in adulthood. There was a significant difference between the mean scores of participants who felt that their cultural traditions in childhood were open to discussions on mental health related topics and those who did not perceive cultural openness on the attributes of knowledge of how to seek information and causes and risk factors. So for the summary of our findings, most of the participants did not feel that their cultural traditions were open to discussions on mental health related topics in both childhood and as adults. And the perception of cultural openness was not significantly associated with religion. However, weak negative significant correlations were found for parent country of origin for both childhood and adulthood and cultural openness and the length of time in the United States and in childhood. So, this being said, we found some differences between races, the correlations of different races, and that is something that we can investigate later. And we are looking into the weak negative correlations in Asians further. We saw that this was happening predominantly in South Asians, but again, this is something to look into in the future. And then for the mental health literacy correlations, there were no significant correlations found between cultural openness and the overall mental health literacy score. However, there were significant weak correlations found between the mental health literacy attributes of knowledge of how to seek information and knowledge of risk factors and self-treatment and perceived cultural openness in both adulthood and childhood. So, moving on to our discussion on the cultural openness to mental health discussions, there was weak negative correlations to suggest that when saying that both parents were born outside of the U.S., people are less likely to think that their cultures were open to talking about mental health, and this could be due to a presence of negative cultural stigma. Research has found that when individuals perceive other religions that they are unfamiliar with, it is often associated with a negative stigma, which can be influencing this perception. And then the same for the weak negative correlations could be said for individuals themselves who were born outside the US and their perception on their cultures being open to talking about mental health. And this could be due to cultural perceptions being shifted or distorted when living in a foreign country, which research also suggests. And overall, this negative stigma can distort mental health attitudes and behaviors. So, in regards to correlations with mental health literacy attributes, there were no significant correlations found between cultural openness and overall mental health literacy scores. The weak positive correlations can suggest that it is possible for those who said yes to cultural openness for their scores to be higher in these areas of mental health literacy attributes. Um, Weak positive correlations between how to seek information and knowledge of risk factors in self-treatment and perceived cultural openness in both adulthood and childhood can suggest that cultural openness can positively influence the knowledge aspect specifically of mental health. And other studies have shown that health literacy in regards to behavior is a more difficult factor to influence, more so than attitudes and knowledge. So that is a gap in the study that we need to address and maybe focus on as a risk factor. So in conclusion, perceived cultural openness varies among the different cultures, depending on how you define culture, and can be influential in mental health literacy, specifically in the knowledge factors. So therefore, we must shift our focus into improving mental health literacy behaviors, because mental health literacy is in regards to behaviors, knowledge, skills, and attributes. So despite cultural differences and the negative stigma that may be in session, we should focus on the mental health literacy behaviors. And thank you.
Thank you so much, Sammy. So we are going to be rolling into the moderated discussion portion of our panel. This is an opportunity for us to synthesize. So we had 4 different levels of influence, or 4 different levels of the socio-ecological framework that we were looking at. So I have some questions for each of us with regards to some of the things that we found. So one of the things that spanned across all of our findings was that our mental health literacy scores were good. They were decent. So they weren't on the lower end, they weren't necessarily on the upper end. And compared to previous studies, we're kind of right in the middle between freshmen and mental health professionals. So we're doing pretty good. So questions to my research colleagues. So why do you think the scores were high when we consider our sample that we have here and what we know about the population?
I can go ahead and answer that. So from Shannon's presentation, we did see that the majority of participants were a part of Kiran Patel's College of Osteopathic Medicine, which is a medicine-dominated college. So individuals going into this might already have a background of health literacy or mental health literacy. And also we have that bias that people going into this study are interested in mental health literacy, which can then maybe suggest that they already have high literacy scores if this is a topic that they are passionate about.
Very true. Thank you so much, Sammy. Anyone else have anything to add to that?
I can add to this. So potentially, since our sample was only from Nova Southeastern University, there could be further confounding variables such as how good our student support system is. We do have the Henderson Center on campus that does provide students with mental health support and 10 free sessions. So just given the nature of the school and how involved faculty and staff are with being interested in student mental health, that could play a factor as well in terms of students having higher mental health literacy if they are attending these 10 free sessions or taking part of even making up the staff of this Henderson Center that we have on campus. We do have student care coaches that work for the Henderson Center, so that could also be a factor.
Thank you, Zara.
Yeah, I mean, just to go off of that, yeah, my presentation definitely went into a lot of the education, but not only education, but I think sometimes it's overlooked how much social media has been playing a role in understanding mental health literacy, understanding the different aspects of mental health disorders and how to recognize them. I mean, even though it's not the most accurate information all the time, that it can influence how people view it versus just not being completely unknowledgeable on it.
Thank you so much. So the next question, so while the previous question looked at how well we were doing, there were some areas of concern. If we looked at the areas where there were kind of lower scores with relation to the attributes, so scores like for the knowledge of risk factors and causes, we had like a 66.5, as well as knowledge of self-treatment. That one was lower than some of the other attribute scores. So, given, these particular ones, so not knowing risk factors or causes, or how to help oneself, right? Why do we think these scores were lower compared to some of the others?
I can go ahead. So knowledge in general, when related to mental health literacy, is usually, if not taught in schools, up to the individual themselves to obtain. If they aren't in, a medical major or taking classes that really teach you about these risk factors and causes or knowledge on self-treatments. And also, you are more likely to have more knowledge on this if you are experiencing it yourself. So that you do go out of your way to research. But a lot of individuals don't necessarily have this knowledge just by the get-go. They have to really look into it themselves. So that being said, if it's not based on experience due to either classes or their personal life and mental health status, then that knowledge could be lower in a lot of individuals.
Yeah, so definitely going back to that idea, what you said about there being that bias. So those who are either involved in it or interested in it are gonna look that up as well. I think I have this question. Well, actually, I'll ask that question towards the end. Anyone else to add for this particular one on, why we might have some challenges, I would say, in these particular areas?
Yeah, through the research of like education, how it's linked, that it's still very highly stigmatized with mental health and understanding, how to seek the help because of the embarrassment, because of the shame. There's a lot of students who report that they're afraid that their program will look down upon them. Medical students are afraid that it'll be noted on their document that they have some. So there's a lot of the stigma and that fear that I think that it's better not to know about it rather than to know about it. So I think by addressing the stigma, we can really improve these attributes. But definitely the stigma in the university population, I mean, fortunately, it has been a like increasing the awareness of what's going on in mental health, but there's still many students who, and related to cultural factors, that this is still very highly stigmatized, especially also in a professional setting.
Very true. Thank you. So one of the things that we did today was we kind of pulled together this matrix of the significant correlations that we found. So looking at all of the socio-ecological level. So we have mine with the mental health experience. We have Zara's family openness. We have our education factors and culture. So we compiled together, because we saw them all separately, but we compiled together where we found these significant correlations, and albeit most of them were weak, positive correlations. We did have a few that were moderate to strong. But here we have it laid out on here. And this kind of visually gives us an idea of, how some things can, be working together or possibly working well. But it also gives us an idea of those gaps, right? Especially when we're looking at culture and we're looking at, some of the variables as well. So with that, I have a question. So, we found that there were differences in the significant correlations. And also when we looked at mean mental health literacy scores and the ones with the attributes, when we looked at the variables that were related to children, right, or childhood, as opposed to the variables that were related to adulthood. So we had Sammy, you had questions about cultural openness in while growing up, and Zara, you had family openness in childhood, and Shannon, you looked at primary schools and things like that before they got to the university level. So why do we think that we're seeing like this difference? And I know Shannon, you talked a lot about what's lacking in primary schools. So you don't have to get into that again if you don't want to, but why do you think we're seeing this difference between this perception of or not perception, but what's happening in childhood as opposed to what's happening in adulthood?
So I can touch on this. So I think based on the interpersonal level, when we look at childhood, we're looking at individuals that are still probably living at home. They're surrounded by kind of an in-group. So they're not really exposed to different cultures or different people of socioeconomic statuses as of yet, which they do experience in college. So this kind of seclusion, it may result in not enough exposure to different risk factors. Maybe their family had zero mental health issues, and they were never able to kind of see like, okay, what does a panic attack look like, or what are depressive symptoms, just because simply they were not exposed to it, considering that they are living with the same people over a long period of their life. As opposed to this, so when they go to college, you're now living with roommates. That could be a randomized, you are exposed to a variety of different people coming from different socioeconomic statuses, people from different states. So you are exposed to people from a lot of different backgrounds. And I think that can lead to a lot of improvement or knowledge in terms of different risk factors and just improving your mental health literacy in general.
Yeah,
Great.
and in addition to that, my focus was on culture, so cultural stigma too plays a factor. I believe that stigma is a lot of the times learned and taught by family and parents, because it is sort of this inherent bias that people hold. So when in childhood, that's what you're surrounded with and that's what you're taught. And then in adulthood, when you, again, like Zara was saying, you're open to more individuals with different socioeconomic backgrounds, cultural backgrounds, different ideologies. That's where these differences come into play, and some stigma can be influenced and changed.
Yeah, and then to touch on the primary school, well, as I said, there was a lack of the standardized in the primary school, because there also, it is noted that children in primary school are now developing their mental health identity almost, and that certain disorders will start manifesting at that. There's no debate on that, but what happens is that in the school systems, the teachers are unsure how to integrate it into the curriculum. They don't feel equipped to. So again, those are being the standardized factors. When compared to like in college, professors and instructors are usually well versed into what they're teaching. It is part of the curriculum. It is meant for, like, if they're taking a psychology course or something that integrates mental health in there, it's more simplistic, and again, they're well prepared. So that tends to be a little bit of the big difference as we see in the primary school now into the college. But hopefully, as the research is progressing and there are more interventions that want to look into how mental health literacy interventions can play a role in childhood, that is why. And then another thing through my research is that primary schools are trying to more touch the parents versus the students directly. So a few studies that I stumbled upon was that primary schools are trying to educate parents of children that are in primary schools, so that way they can be able to be better equipped to improve the mental health literacy through that indirect pathway. But nonetheless, the college courses tend to have a better instructor, a better standardization. And again, students have a bit more understanding of the world when they enter universities as well.
Thank you. And I think to add to that as well is, how we approach mental health, education nowadays is we do it, and just even from a health literacy perspective as well. I mean, often one is not well versed in diabetes until there's a family member or oneself, has to learn this information. So this is not necessarily something that we're going to get in, primary school or during health class, and learn what is diabetes and, what does it mean to measure your A1C levels. And the same thing for, I think, mental health as well. So we end up having a reactive instead of proactive or preventative approach. And I think that's part of it as well. So while young adulthood is when we usually start seeing onset. I mean, we see in children as well, but especially during the pandemic, we have a lot more kids, especially with being home and homeschooling for short periods of time. There was increased social anxieties and things like that. But I think we had this reactive approach to mental health instead of, really teaching kids about stress management and, here are some options, or these are the doctors that way you go to if you had, issues with your mental health, or even describing what mental health is. So I think, just how we approach mental health in general has that aspect as well. Our very last question, we had some more, but in the interest of time, we'll ask one more question. So we know that, so I guess my general question is like, if we were to, now that we know all of this information, I'll go back to the matrix that we have. And again, we know that a lot of our correlations are weak correlations, and we know what comes along with that. But knowing what we know now, at least with our sample, right? So we may not be able to generalize to all universities, but at least for our university, like, what would, programming look like going forward? Like, what would you want to focus on? What do you think we should do in order to improve mental health literacy, especially among these attributes that may have certain gaps or something like that? So what are some ideas that you have for this particular sample and this particular university community based on what we know now from, the results of this study? And it could be from your area, or it could be like an overlap of the other factors that we looked at.
Yeah, so based on the correlations with education, it's kind of like a torn thing between really trying to target the primary and secondary schools. However, I understand the big obstacle of the curriculum and a lot of those kind of loopholes that need to be adjusted in order to really make it standardized. But I do think it would probably be more beneficial that students do get that exposure and do get to have that awareness in primary and secondary school. However, on the other side, because of maturity and because of life experiences, college tends to be where I think they will really retain and really be able to relate with the knowledge that is being conveyed to them in these mental health programs. And plus, if it's some area that they are interested in, like dealing with people, it may be a more beneficial because it's on a voluntary basis. And again, you have a more trained professionals treated to teach these students that. So I mean, I think the most effective would be the college, but I do think having that exposure could definitely, in primary and secondary schools, could also be very beneficial.
Thank you, Shannon.
I can, oh, sorry.
Sorry. Yeah, in addition to that, so for my topic specifically, looking at cultural openness and stigma surrounding cultures, that's something that's very difficult to change, especially as we saw in the childhood aspects. So really focusing on students in that university setting, and trying to destigmatize and also shift our focus from knowledge to behaviors. In community health, we're taught that changing not attitudes and knowledge is the first step, and changing behavior is always in the long-term outcomes, because that is a more difficult thing to influence. So finding some way to not only increase their knowledge on these mental health literacy related aspects, but also getting to move from that stigma and whatever they perceive their cultural perceptions and openness from their childhood to adulthood, having some effect there in the university setting to, move towards changing in behavior.
Okay,
Thank you. Go ahead, Zara. I'm sorry.
So since we saw no correlations with knowledge of risk factors and causes, I think that a potential intervention, at least on Nova Southeastern's campus, would be incorporating some type of, whether it be like the 8-hour mental health first aid training, or just maybe an abridged version of that, just having some sort of presentation within this class called UNIV, which is the first year seminar that all freshmen are required to take. Something that kind of just standardizes mental health education in a university community would definitely benefit everyone in terms of increasing their mental health literacy, and maybe we can establish some sort of correlation after that.
Thank you, Zara. I agree. I definitely think having these targeted opportunities, and I guess that's the to be continued for our research, because we have implemented the mental health first aid trainings, and now we get to look at to see whether it has done a good job in increasing mental health literacy overall, but also in these specific areas as well. So that is to be continued for us. So thank you. I want to thank my panel so much for all of their hard work outside of their classes in working on this particular project, especially as our grant program comes to an end. I don't see any questions in the Q&A, but we do have a couple minutes if there's anyone that wants to ask a question for one of our panelists. And in the meantime, if you have any other questions that you think of later, my contact information is here, my email, our mental health literacy project. We have an Instagram page. We also have a LinkedIn, as well as my Instagram. If you're wanting to connect, please connect with us.